Right, we are live on YouTube. Should we start?
Just give me like 15 seconds.
All right.
Just seconds. Okay,
You're ready?
I'm ready.
Okay, so am I. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 9G, which is Cytopathology. We are streaming live from Kuwait City via Kolkata. Today we have a very interesting topic, which is FNAC of Pancreas, Session 1. And in this Session 1, the subtopic is the PSC system of reporting pancreatic FNAC. So this is something very important, very new, and we all need to understand that. And also we have the multimodal diagnostic approach in cystic lesions of pancreas. As we all understand, pancreatic lesions have to have a multimodal diagnostic approach to exactly come to a conclusion. And to talk on that, we have Dr. MALLIK, who is an MD from PGI Chandigarh. Presently is a consultant cytopathologist in Mubarak Kabeer Hospital, Kuwait. Dr. MALLIK has been working as a consultant in cytopathology for more than 2 decades there, and also has been teaching graduates and postgraduate students in pathology and laboratory medicine for about 2 decades or more. He has multiple publications which are his research papers in international journals of repute. His areas of interest include soft tissues, thyroid, gastrointestinal tract, and pancreatic pathology. Along with that, he has special interest in human papillomavirus detection and genotyping in cervical cancers. Before I ask Dr. MALLIK to start, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. MALLIK, sir, please share your screen and let us start.
Right. So,
Yeah, please make it full screen. Right, just press that hide thing so that that pop-up just disappears.
yep.
Great, please start. Thank you.
So we are ready to go. Thank you, Nadeem, once again, and a very warm welcome to all of you. So, first of all, a little bit of an apology because I had to change the topic, modify the stuff that I'm going to be dealing with in this webinar. So, for the first session on pancreatic FNAs, I'm going to talk about the Pathology system of reporting pancreatic FNACs, and then I'm going to discuss the multimodal approach to the diagnosis of cystic lesions. In the next session, I'm going to be talking about the solid lesions. So, the outline of this session is going to be as follows. First of all, I'll talk about the role of cytopathology in the management of cystic lesions of the pancreas. Next, the importance of a multimodal approach in general. And then the multimodal approach with respect to cystic lesions, including cytopathology, biochemical analysis of cyst fluids, the role of molecular cytopathology. I'm going to talk about the Pathology Society cytopathology system in reporting pancreatic FNA at the last part of this particular webinar. So I guess that if we do the first part, it is going to be easier to understand the reporting system better. So I've decided to keep it towards the latter half of this particular session. So first of all, what is the role of cytopathology in the management of cystic lesions of the pancreas? In order to understand that, we need to remember that there are a number of guidelines which are available which deals with the management protocols in cystic lesions of the pancreas, and these are some of the guidelines. It doesn't necessarily mean that all these guidelines agree with each other. There are significant differences, but this is just to give you an idea that there are a number of guidelines. And in all these guidelines, according to all these guidelines, cytology plays an extremely important role in the decision-making process. So just to give you an example, I know this is the graphics are pretty small, but still, this is the American College of Gastroenterology guideline for pancreatic cyst. And as you can see over here, that it is a kind of a multimodal approach in order to come to a particular decision. And FNA plays a very significant role, and this is the same diagram with the role of FNA being highlighted. So according to this guideline, if there are cysts which are seen on imaging and the radiographic diagnosis is that of a non-neoplastic cyst, or if there are classic imaging features of a serous cystadenoma, no further evaluation is recommended unless the patient is symptomatic. However, if there is a history of pancreatitis, or if there is obstructive jaundice or an associated solid mass, things are different. If there is obstructive jaundice or an associated solid mass, FNA plays a very important role. And the remaining part of this algorithm deals with a number of parameters, many of which are related to the imaging findings, but in each and every branch of the tree, you can see that FNA does play a very important role in the decision-making process. So, if we can just put them together and try to just summarize it to the very, very vital point, these are the ones I think that we should remember. FNA does play a very important role in the decision-making process related to surgical interventions or surveillance. So when there is a pancreatic cyst, there are three things that you can do. You can just leave the cyst, you can just forget about it and let the cyst be, or you can decide on removing the lesion surgically, or you can put the particular lesion under surveillance. Surgery is optional in serous cystadenomas, pseudocysts, lymphoepithelial cyst, and intraductal pancreatic mucinous neoplasms, which do not show high-grade atypia. This is extremely important because there are a number of patients where by giving a correct diagnosis on FNA, you can avoid surgery, and that is very vital, and I shall tell you why a little bit later on. However, surgery is recommended in IPMNs with high-grade atypia, in mucinous cystic neoplasms, and solid papillary, pseudopapillary neoplasms, cystic neuroendocrine tumors, and cystic acinar cell carcinoma. So you're going to see a slide when I'm going to put all the cystic lesions together. It's going to come through very soon. So the role of FNAC is as follows. The major role is the risk assessment for malignancy in cystic lesions, and of course to reduce unnecessary surgeries. This is very important, since pancreatic surgeries are associated with significantly high risk of morbidity, because when you look at the patient profile, you're going to see that many of the cysts affect the patient population in an age group where a number of comorbidities are present, and many of the patients may not be fit for surgery. So it is extremely important that when we know that something is benign based on what I showed you in the previous slide, we say so. If you try to sit on the fence too much and call too much of atypia, we might be putting a number of patients on the surgery table who may not actually need surgery. And to do that, a multimodal approach is extremely important. So what are the cystic and predominantly cystic lesions of the pancreas? So this is about the list of the common lesions and some uncommon lesions. So at the top of the card, you have serous cystadenomas. Then you have the very, very important group of tumors which play a very important role. Mucinous cystic tumors, which comprise of two different kinds of tumors, mucinous cystic neoplasms or MCNs and intraductal papillary mucinous neoplasms, which have got other subtypes. I'm going to talk about them later on. Then of course there are the pseudocysts, lymphoepithelial cysts, and not to forget that many of the tumors which I'm going to be talking about in the next session can also show cystic degenerations. And the ones which can show cystic degenerations are the solid pseudopapillary neoplasms, neuroendocrine tumors, almost 10% of them can show cystic degeneration. Cystic acinar cell carcinomas are extremely uncommon, but we can have a variant which shows cystic degeneration. And then there are enterogenous cysts, endometriotic cysts, they're very rare, retention cysts, acinar cell transformations and parasitic cysts, just to complete the list. So what is this multimodal approach? So it starts from very, very basic stuff that you see or you should see honestly on the clinical request form. This part, the clinical history, is quite often missing in an adequate amount. So you have to take a very good clinical history. Age and sex, extremely important. The imaging findings should guide you in the right direction, but most of the time it is the gastroenterologist who should be the ones who look at the imaging findings and take the final call. You should know the method of obtaining the aspirate. There is possibly no other site in the body where the method of obtaining the aspirate, the knowledge of that is as important as it is in this case. Biochemical analysis of aspirated cyst fluid, very, very vital. In certain circumstances, possibly more important than what we see under the microscope. Of course, light microscopy, that's why we are here, using routine stains and immunohistochemistry, and a very, very important role of molecular cytopathology is known in this particular, in these lesions. So, the first important point, as I told you, is we should know how the sample was obtained. Now, traditionally, we used to obtain samples from pancreatic lesions through a percutaneous ultrasound or CT-guided FNA. Now, that has almost completely been turned on its head. We are now in an age where we do endoscopic ultrasound-guided FNA, which has become increasingly adopted in many centers around the world, and in most of these places, it has become the method of choice. It is extremely operator dependent, supposedly has a very steep learning curve, and your diagnostic accuracy, of course, like any other place, is going to depend on how good the samples that you are able to get. Luckily, at the place where I work, the gastroenterologists that work here with us, they're extremely good in getting good samples, and we have seen that our non-diagnostic rates are extremely low. So most of the time, we are able to get them a very specific diagnosis. And under various circumstances, I can tell you that they go ahead with their decision, therapeutic decision, without doing a biopsy. Mostly what I'm talking about is in case of solid lesions, of course in cystic lesions too. Now, endoscopic ultrasound-guided FNA is better than other methods, and why this has happened is because compared to the traditional methods of ultrasound and CT-guided FNA, endoscopic ultrasound-guided FNA are better in distinguishing adenocarcinomas from chronic pancreatitis. We're going to talk about them in the next session, and localizing lesions smaller than 2 centimeter, and also and also in staging. So there are two major approaches of endoscopic ultrasound guided FNA in pancreatic lesion. For lesions which are located in the head and the unsned process, it is a transduodenal approach. Whereas in lesions which are located in the body and the tail of the pancreas, it is a transgastric approach. This is a crucial bit of information. That is because that when the lesion is approached through the transduodenal route, almost always you're going to get contamination from duodenal epithelium. And if it is obtained from the transgastric route, you are going to get contamination from the gastric epithelium. And these epithelial cells, because of their appearances, might be easily confused with lesional cells coming from inside the cyst, which of course they are not. And so you should be very clear about the various morphological indicators which should help us recognize these cells as normal cells from the gastric and duodenal epithelium. So there's a couple of diagrams here to show you that how lesions which are located in the stomach are approached through the transgastric route, in the body and tail of the pancreas are approached through the transgastric route, whereas those which are located in the head of the pancreas and unsned process, they are approached through the transduodenal route. So these are a couple of pictures showing you a lesion in the tail of the pancreas going through the transgastric route, and the other one, a lesion in the pancreatic head going through the transduodenal route. And I would like to thank Dr. Ali for providing me with these photographs. So, first of all, let us look at the normal cells and the various procedure-related contaminants. As I said, this is extremely important. First one on the list are duodenal epithelial cells. Now, duodenal epithelial cells, you get a very good clue when you look at them at low magnification. The clue comes from the fact that these are the seeding of goblet cells, these structures here, which are present on the sheets of duodenal cells. So just by looking at this particular sheet at this low magnification, you know that these is duodenal epithelium. Okay, so these are large sheets of cells. They should not be confused with lesional cells. And please take the clue from these little white spots of goblet cells. If you go at the higher magnifications, duodenal epithelial cells, even if you do not see the goblet cells, the smaller clusters, look at the edge of the cells and you're going to see the brush border. So this is something which is a very good indicator and should help you identify these cells as duodenal epithelial cells. So after the duodenal epithelial cells, we need to look at the gastric epithelial cells. Now the gastric epithelial cells, the key diagnostic indicator is that you need to look at the surface. And at the surface, you find this mucin, this gastric foveolar cells that show mucin, and the so-called mucin in cups. The mucin cups are present over here. So these are mucin cups. And by looking at these cells, you should be able to say that these are gastric epithelial cells. Remember that one of the lesions that we are going to deal with a little bit later, and that is intraductal papillomucinous neoplasms. Very commonly, the lining epithelium is gastric foveolar type cells. So we have to be very careful that we are not dealing with gastric epithelial cells and dealing with the cells of IPMNs. Okay, so this is a pitfall in diagnosis. So IPMNs with gastric foveolar epithelial lining, they resemble gastric epithelial cells, of course, because that's what they are. The next one, pancreatic acinar cells. So these are pancreatic acinar cells, and sometimes because of their shape and because of sometimes if they're not present in this kind of an acinar pattern, if they're present individually, because of their location of the nucleus, kind of a plasmacytoid location of the nucleus, eccentric location of the nucleus, these cells might look like cells from a neuroendocrine tumor. So one needs to be very careful about that. Look at the quality of the chromatin to differentiate and a few other features. This is pancreatic duct epithelium. So as you can see over here, they are recognized by the fact that this very evenly placed honeycomb pattern. And look at the even spacing. The appreciation of this is very, very important, because we are going to deal with this in detail in the next webinar, when you are going to see how they compare with well-differentiated pancreatic duct carcinoma. So very, very even distribution of cells, but sometimes, even if it is not malignancy, you can start seeing a bit of folding, you can see a bit of overlapping. So, but this is somewhere in this, like in this particular slide, you can say for sure that this is benign pancreatic duct epithelium. Here, this slide, they have not been separately labeled, but to the left, what you see is mucin, which comes from the GI tract, and to the right is mucin, which has come from a mucinous neoplasm. Now, if you look at these two carefully, you're going to see that the pictures to the left, the mucin is extremely thin, okay, and to the right, it's just an optical quality. It shows it's very thick. It shows this very long, like paintbrush strands, which I like to call them. So they look different. So this is mucin from the GI tract, and this is mucin from the lesional epithelium. But at this point of time, I would like to say something, and that is, under a lot, in many situations, a mucinous neoplasm may not show this thick mucin. Almost 50% of mucinous neoplasms may actually show a very thin kind of a mucin when things become very difficult. And under those circumstances, we have to rely on other modalities, which we are going to discuss a little bit later on. So to the left, mucin from the GI tract, very thin, and this is the thick mucin that you almost clinches the diagnosis. I mean, if you see mucin this thick, you need not do any other tests like molecular tests or even biochemical cyst fluid analysis to say that, well, this is indeed a mucinous neoplasm, whether it is be a mucinous MCN or whether it is an IPMN. So this is a very important slide. So now going to the multimodal approach, first of all, let us look at the gender and the age and pancreatic cysts. Not quite often we see such a kind of a grouping. Let's look at these pictures very carefully. So for serous cyst adenomas, most of them are in the 60s and 70s, and many of them, almost, this part is missing, I don't know, almost 75% of them are women. So serous cyst adenomas, women in the 60s, 70s, and also in the 80s. So mucinous cystic neoplasms are very interesting. 99% of mucinous cystic neoplasm occur in women, and most of them are in their 40s and 50s. Very, very important point to remember. IPMNs in both types, males and females, almost a 50-50, and they occur between 60 to 80 years of age. Lymphoepithelial cysts, males a little bit more than females, within 40 to 60 years. So this is extremely vital from the angle of your decision-making procedure, as you are going to see later. Now, what about the locations? Pseudocysts actually can be located anywhere. Some studies show that they are more common towards the tail. Serous cyst adenomas, most frequently found in the tail of the pancreas, but can occur anywhere. Mucinous cystic neoplasms, and this is very crucial, they most often occur in the tail and the body of the pancreas. They almost never, it's very, very rare to find mucinous cystic neoplasms in the head of the pancreas. IPMNs are of various types. We are going to discuss those types later on. But in the main duct type, 2/3 of them occur in the head, and the rest can occur in the body and the tail. The branch duct type, mostly the head and the uncinate process, and it can also occur in the rest of the body, parts of the pancreas also. Lymphoepithelial cysts can occur anywhere. So this is a kind of these are helpful clues. And if you have to take one message from the last two slides, it is this. it appears that of all the cystic lesions, the mucinous cystic neoplasms are the best providers of helpful clues because, first of all, remember that they avoid men. So be very careful. I mean, there are very, very rare case reports of mucinous cystic neoplasms occurring in men, and they also avoid the head and the uncinate process. This is very vital. So what about the history? A history of, so if there is a history of acute or chronic pancreatitis, it may support a diagnosis, help you with the diagnosis of a pseudocyst. Similarly, history of abdominal trauma, surgeries like those related to the stomach. Okay, partial gastrectomies are often associated with pseudocysts, presence of obstructive neoplasms. All these are important parts of the history sheet. So now let us take some time to look at some of the key imaging pointers. Pseudocysts, and now this decision making is done most of the time by the radiologist or the clinicians. They're going to look at it and they're going to put their impression, but as cytopathologists, we should be aware of these findings. So pseudocysts are mostly unilocular without any solid component. That's a very vital point about pseudocysts. Serous cystadenomas, so 45% of them are microcystic, whereas 32% are macrocystic, around 18 are mixed micro and macro, and there can actually be 5% solid serous cystadenomas. The central scar, which is a very, very well-known finding, is present in only 30% of the cases, so 70% of the cases will not have a central scar. They are lobulated, and they can have a kind of a hypervascular enhancement, as a result of which they can become difficult to differentiate from neuroendocrine tumors, which can also have hypervascular enhancement. So it may be difficult. You can come across situations where your gastroenterologist or your radiologist is going to tell you that, see, it could be a serous cystadenoma, but I cannot exclude that it might be a cystic neuroendocrine tumor. In this lesion, there is no communication between cysts and pancreatic duct. In mucinous cystic neoplasms, they are macrocystic and the cysts have thick walled septations, and in about 25% of cases, there is peripheral calcifications. They do not communicate with the pancreatic duct. IPMNs, both of them, they communicate with the pancreatic duct. In the main duct type, there is a distension of the major pancreatic duct, whereas in the IPMN of the branch duct type, they have more of a microcystic kind of an appearance. Right. What is the role of cyst fluid biochemical analysis? All this even before we go into the cytomorphology. Very, very vital. So let's look at, so there are two major enzymes which we should analyze. CEA and amylase. I know that some do lipase, but it is not really that necessary. Let us see why it is important. So if you have a cystic lesion where you have sent the fluid for CEA and amylase analysis and neither of them are raised, then you are dealing with a serous cystadenoma, because serous cystadenomas will not show a rise in CEA, they will not show rise in amylase. So both of these two things are not raised, indicates a serous cystadenoma. And because serous cystadenomas are usually those tumors where surgery is optional, that you can avoid surgery, this is a very, very important finding. So if you have a cyst with both these two enzymes come back negative, it's pretty good for a serous cystadenoma. They've got some certain other implications, and we are going to talk about that when we discuss the Papa-Nicolau system. Pseudocysts, the CEA levels are typically not raised, but the amylase levels are markedly raised. They're raised to the level of like thousands, okay? They're not just slightly raised. In mucinous cystic neoplasm, this is the key, the CEA levels are raised in mucinous cystic neoplasms and raised in IPMNs. Okay, so this is kind of the general rule, but remember that the levels of amylase may be raised in IPMNs as well as mucinous cystic neoplasms. They're believed to be more commonly raised in IPMNs than in mucinous cystic neoplasms, but there is considerable overlap so that you cannot use this to differentiate between mucinous cystic neoplasms and IPMNs. So this is kind of a rule, but there are crucial caveats in the above findings. And please, and this is just as a note for somebody who might like to come back and see the slide later, do not use them without understanding the caveats, for which you need to take a look at the next two slides. And let's look at these issues right now. What about the CEA? So first of all, a sufficient amount of cyst fluid for CEA analysis may not always be available, and extremely viscous mucus-rich fluids are unsuitable for biochemical analysis. Now here I would like to say, first of all, they're unsuitable for biochemical analysis, and second of all, when you see something, it is very thick, very mucus, okay, and you're sure it is a mucus-rich lesion, you actually do not need to send it for biochemical analysis because you already know that this is a mucinous lesion. Of course, one has to remember that if you look at just gross pictures, sometimes pseudocysts, which are very severely inflamed, can show a kind of a mucoid appearance. So what is kind of a cutoff? The cutoff, according to a study, and this is almost like the main reference point, which when people like to look at, by Bruges et al., published in 2004, is roughly about 192 nanograms per milliliter. Is a cutoff which is most often used, right? But it can be much higher than that, and it has been seen that if you raise the cutoff levels, then you are going to miss some of the cysts, but it's going to be more specific. And if you lower it, what is going to happen is going to be less specific and more sensitive. So this is roughly about 192. 192, 200, so 192 is actually the point. So if you want to remember 200, it's easier to remember, so 200 is pretty good enough. Now, using this, the sensitivity is 75% and specificity is 84%. According to some of the recent studies, they have shown sensitivities and specificities as low as 63 to 62%. What does that mean? It means that because of these two values, it means that because a sensitivity of 75%, it means that there are mucinous tumors which do not show raised levels of CEA, and the fact that all tumors with raised CEA levels may not necessarily be mucinous tumor. So it is not really set in gold. It is extremely useful, but you have to take the whole scenario into consideration. You have to remember that there are mucinous tumors which do not show raised CEA levels. And of course, there are tumors which are actually non-mucinous, which can show CEA levels. One of the biggest party crashers in this should be the lymphoepithelial cysts, and even some enteric cysts, which are pretty rare, which can show very high CEA levels. Next of all, point to remember, as much as we would like it to be, CEA levels do not differentiate high-grade dysplasia or invasive CAs in MCNs and IPNs. So you cannot look at the CEA level and say that because the CEA levels of this particular mucinous lesion is higher, much higher than others, this is more likely to harbor a high-grade dysplasia or malignancy. No, that is not the case. So CEA levels do not correlate with malignancy. So what about the amylase issue? An amylase level which is lower than 250 international unit per liter excludes pseudocysts with almost 98% certainty. So pseudocysts must have high amylase levels, and in spite of not communicating with the main pancreatic duct, this is a very key point. So amongst the mucinous cystic neoplasms and IPMNs are the ones which connect to the main pancreatic duct. That's where the amylase comes from. So one expects that if one has to differentiate between the mucinous cystic neoplasm and IPMN, one must just say that, okay, if the levels of amylase is high, it is most likely a IPMN. That is not the case, because there are, for some reason, some mucinous cystic neoplasms show high amylase levels. So you cannot use amylase levels to differentiate between them. So let's start with some cytopathology. First of all, pseudocysts. The gross appearance of the cyst usually thin, non-mucoid, clear to brown to greenish. So you get a good clue from the gross appearance. But remember, this is a very important point. If there is heavy inflammation, pseudocysts can appear mucoid. Microscopically, there are no epithelial cells. It shows a dirty background with cell debris, neutrophils, lymphocytes. Hemosiderin-laden macrophages are present and they may contain bile. But sometimes you may not have a dirty background. You may have a clean background with just foamy macrophages and inflammatory cells. The pitfalls to keep in mind are contamination with acinar cells, GI content contaminations, and debris from lymphoepithelial cysts. These can look very dirty. We are going to see some pictures later on. So a careful analysis to morphological details and cyst fluid biochemical analysis can help in these cases. So this is a pseudocyst with a clean background, and here you can see the bile pigment over here. This is seen pretty commonly. And in this pseudocyst, what you see is actually a foamy macrophage with a very punched out vacuole, looking almost like a signet ring cell. Sometimes they actually push it. I don't have a picture of that. You can just push this towards one of the edge. Looks like signet ring cells. So please don't overcall them. You can have punched out vacuoles in pseudocysts. Next, in line serous cystadenomas. So to the left, you're going to see a picture which actually shows nothing because it's just blood mixed with some fluid, mixed with a few cells lying here, inflammatory cell lymphocytes lying here and there. Now that, I have put that thing there just to tell you that this is what you see most often. Most often, in more than 75 or 80% of the cases, you are not going to see the epithelial cells that you expect to find that you are seeing on the right slide, which are these rounded cuboidal epithelial cells, which actually contain, if you do a PS with and without diastase, you can show the presence of glycogen. So this is typically the cells which are cells of serous cystadenomas are usually not present. And if you are unable to see the cells, it is okay to put the possibility in your diagnosis in case of supporting imaging and biochemical analysis, showing that there is no rise in CA or amylase. So that's very important. No rise in CA, no rise in amylase. You do not find any cells, you can still put a possibility of serous cystadenoma. Mucinous cystic neoplasms, the two key points are, this is very important. Only about 50% of mucinous cystic neoplasm contain thick viscous mucin. So it is the other half which is a much bigger diagnostic challenge, and you should send for biochemical analysis, and sometimes you may even require molecular pathology. Right, and it is very important that even after you call something as a mucinous cystic neoplasm, to study the cytomorphology closely to determine whether high-grade ATPI is present. So mucinous cystic neoplasms, according to the WHO classification, can be actually graded as follows: low-grade intraepithelial neoplasia with, I'm sorry about this. This should be neoplasm with with high-grade intraepithelial neoplasia. This is a mistake. So mucinous cystic neoplasms with high-grade intraepithelial neoplasia and mucinous cystic neoplasm with associated invasive carcinomas are together, they are called high-grade atypia on cytomorphology. Extremely sorry about this one. So this is high-grade atypia and associated invasive carcinoma. So we are looking for these changes. When you say high-grade atypia on cytomorphology, they are actually covering these two lesions. So what are the important features that you look at in order to say if high-grade atypia is present? You try to look at a high nucleocytoplasmic ratio. These are very predictive. Nuclear membrane irregularities, abnormalities of chromatin, presence of small size cells, small means smaller than enterocytes, which are present on the smears, and presence of background necrosis. So these are 5 features which are considered to be important. In our experience, we have found that apart from these 5, if you look at the clusters and you look at the polarity of the cells, if there is deranged polarity and architectural disarray, that is also something which suggests the presence of high-grade atypia. This is a collage. I couldn't help but putting this of mucin, and it looks pretty stunning from various angles, very thick mucin. You can see this kind of strands like paintbrushes. They also trap RBCs in very spectacular ways. So this is all the stuff where you can be pretty certain that you're dealing with mucin and nothing else, and this is very vital. So this is a low-grade mucinous cystic neoplasm, as you can see over here. It's mucinous with mucin, but the cells are pretty uniformly placed. Nuclei looks to be a little bit hyperchromatic, but it's okay. I mean, maybe because of the way the picture has been taken, because sharp nuclear outlines, not a very high NC ratio. It's pretty okay. I would call this a mucinous cystic neoplasm. Low grade, another low grade, little bit of an overlap. Again, very sharp nuclear outline. The nuclear cytoplasmic ratio is not raised. Pretty good maintenance of polarity. This is just kind of an overlap, low grade. Now, when you compare this with this one, this is what I would call high grade. One of the main reasons I told you in high grade what happens is that look at the derangement of the polarity, and then isonucleosis, which is, well, not that important a feature, but the most important factor over here, as I can see, is the derangement of the polarity. Of course, there is irregularities of nuclear membrane and some degree of abnormalities of chromatin. So when you see these features together, this suggests high-grade mucinous cystic neoplasm. This is another one, I'm sorry. Yep, there is, I think it's come out better. Look at the regularity of the nuclear outlines. Look at these, right? And abnormalities of chromatin. So, and there is also appears to be a bit of necrosis which is admixed over here, which is also pretty highly predictive of a high-grade ATP. You have to remember that cytology may undercall high-grade ATP in many cases because of the corresponding changes in the cyst wall may be focused. When you look at histopathology, you know that the atypical changes, the high-grade atypia, may not be present uniformly across around the wall of the cyst. And therefore, if you call something as low-grade atypia, don't be surprised if when you do a histopathology, there are areas showing high-grade atypia. Next, intraductal papillary mucinous neoplasms. They are of three major types: the branch duct IPMN, the main duct IPMN, and the mixed type of IPMN. The branch duct IPMN are the most common types. They communicate with the main pancreatic duct. They may be multifocal, but importantly, they have a lower risk of progression to cancer. Whereas the main duct IPMN is generally associated with the diffuse dilatation of the main pancreatic. That's why radiologists are able to call this one pretty confidently out the entire pancreatic mass, and they have a higher risk of progression to malignancy. The mixed type is very rare. It is a combination of branch duct and main duct, and it is believed that the risk of malignancy is similarly high as a main duct IPMN. So this is diagram showing the main duct and the branch duct IPMNs and some of the mixed types. Once again, I've made the same because I just use a copy paste of this. It should be a high grade intraepithelial neoplasia, not low grade. Sorry about that. And this high grade and the ones associated with invasive carcinoma are the ones which are called equivalent to high grade on cytomorphology. Certainly, I'm going to change this before I send you the presentation or the PDF file to you, Nadeem. So I'm surely going to remember that. Right. IPMN, there are various cell types. There could be the gastric type, the intestinal type, and pancreatopiliary type. We really do not try and separate those on cytomorphology, but you can see different kind of appearances. So it is believed, and many say that it is not always possible to differentiate between the mucinous cystic neoplasm and the intraductal papillary mucinous neoplasm on cytology. It may be so under various circumstances, but quite often we see these structures. We see a mucinous lesion, and then you see these huge tissue fragments, and you can see the papilla here. This is like almost a no-brainer literally, because you can see the papilla and you can say that, well, we are dealing with a mucinous tumor with this kind of papilla. This is IPMN. Look at this one. Papillae coming from the core. These are actually epithelial cells which have been spread like that. Sometimes they really look striking on cytology. IPMNs, and if you look at the edges, you see these cells streaming out. These are the epithelial cells. Some more of the pictures, and here you start seeing this. this is something which you saw a little bit earlier, and these are the mucin caps because these are the gastric foveolar type of cells showing kind of mucinous caps over here. And look at this. Mucin cap here in IPMN and the mucin cap in the normal gastric epithelium, right? Sometimes you can even have a mixture of patterns. This is an IPMN. You usually follow the same criteria with high-grade atypia, with irregular hyperchromatic nuclei, and kind of an architectural and polarity-related disarray. Now, this is a very tricky lesion because if this particular slide comes under my microscope, I just look at this dirty material. I might just pass it off as some kind of acellular material, maybe coming from a pseudocyst, I don't know. And then whenever you see this dirty material from a pancreatic cyst, you should look very, very carefully for the presence of ghosts of squamous cells. So this is one over here. Look at the squamous cell over here. Sometimes it can be nucleated squamous cells. You can see a bit of keratin. And in that case, what you are dealing with is a lymphoepithelial cyst, because lymphoepithelial cysts, although the name is lymphoepithelial cyst, they have a squamous cell lining. Look at this. Just looks like some dirty material. Maybe you might be thinking in terms of a pseudocyst, because we know that whenever you see a dirty background, think of a pseudocyst, but then you start looking at this orangeophilic material over here. This is a lymphoepithelial cyst, right? And these lymphoepithelial cysts are notorious for showing very high levels of CA. So if you can pick them up, you have done a great job. This is a very rare cyst. This is from an article by Kulwinder Das and Dr. Vinod Sidam. And this is a cyst which is actually a ciliated foregut cyst, which was published in Cyto journals. So here the diagnostic clue are looking at the cilia, if you can pick them up on the smears. And the last one I'm going to talk about as far as cytomorphology is concerned are cystic neuroendocrine tumors. We are going to be dealing with that in detail in the next webinar. Just to remind you, cystic neuroendocrine tumors, about 10% of neuroendocrine tumors can be cystic and they can come up, and the other one of course is the SPNs, which can be cystic. So we have to keep that at the back of our mind when you are dealing with cystic tumors with pancreas. So what about molecular tests in pancreatic cyst fluid analysis? So there are a lot of stuff which is available right now, but these are the major ones. So if you send material for KRAS mutations. So what does KRAS mutations do? Presence of a KRAS mutation strongly supports the diagnosis of mucinous cyst over non-mucinous cyst. However, it does not distinguish between IPMNs and MCNs. So if it has a KRAS mutations, it can be either of them. And of course, it cannot predict the grade of dysplasia. So there is no specific mutation that you do on NGS and you say, well, this is with this KRAS type of mutation is associated with a grade of high grade atypia or chance of high grade dysplasia or invasive cancer. No, there are none. However, one thing which might help you to differentiate between IPMN and MCN is the presence of GNAS mutations. Among the mucinous lesions, the presence of GNAS favors an IPMN. If you can show 3P deletions, some of them involving the von Hippel-Lindau gene, it supports the diagnosis of serous cystadenoma and gives you a very, very helpful clue. However, there are some other gene alterations like P10 mutations, T53 mutations. All these things can come up through your NGS studies, along with loss of CDKN2AP16 and SMAD4, which shows or is predictive of a higher risk of malignancy arising in pancreatic cysts. So, why do molecular studies on pancreatic cysts? Why do I do them? The reason is, if you add next generation sequencing and do these studies to cytology, in a particular paper which was published in Cancer Cytopathology by Rosenbaum et al., it increased the prevalence of mucinous cysts from 45.1 to 62.8%. So you can see the number of mucinous cysts which were not detected because of not doing NGS, just doing cytopathology and molecular cyst fluid, biochemical cyst fluid analysis. This is about a 39.2% increase. So NGS really helped. It also improved the correct rate of diagnosis for IPMNs as mucinous from 50% to 100%. Overall, it increased the sensitivity to 70 to 90%. So if we have the facilities, it's really something that one should consider doing, and it helps in patient management protocols. So the last part of this talk, I'm going to be dealing with the Pathological Society of Cytopathology system of reporting pancreatobiliary cytology. I will not be showing you any slides. It's going to be too detailed. I'm just going to be discussing some of the key points related to the terminology. So this was published in 2014, the standardized terminology and nomenclature for pancreaticobiliary cytology, the Pathological Society of Cytopathology guidelines. And what they have done is that they have divided things into a 6-tiered classification scheme comprising of non-diagnostic, negative for malignancy, atypical, neoplastic has got 2 parts, A and B, neoplastic benign, neoplastic others. Then there is suspicious for malignancy and positive for malignancy. And for all those of you who would like to come back later and just take a look at this particular slide, you can see all the lesions. This is like kind of a summary of what is going to follow in the subsequent slides. So what about the key points of non-diagnostic? So one should take the clinical, the imaging, the cytomorphological, the biochemical, and the molecular pathology context, if available, together. Say, for example, you have a completely acellular cyst fluid, okay? But you might still be able to give a definitive diagnosis with clinical findings, imaging findings, gross appearance of cyst fluid, biochemical analysis, or molecular pathology results are taken into consideration. For example, you have an acellular cyst fluid, which shows a very high levels of amylase, levels of Ca are low. You have the clinical history of acute pancreatitis. You can say that we are dealing with a consistent pseudo cyst, which is going to be very, very important for patient management. So acellular doesn't necessarily mean non-diagnostic. And however, if you find any form of atypia, just like any other schemes, it excludes that from the category and you have to put it in the category of atypia. What about negative for malignancy? So, in situations where biochemical analysis results or molecular pathology results are unavailable, this is one thing one has to remember. So negative for malignancy, if you have the biochemical results and molecular pathology, it is very good. But what if you do not have it? If you do not have results of biochemical analysis, you do not have molecular pathology results, it is very reasonable to report such aspirates as a negative cyst, because to the clinician, after he or she assesses the clinical and imaging findings, he might find such a report much more helpful than you just calling it a non-diagnostic report, right? So even if you do not have these, even if you're working under limited circumstances, even then you can say that, well, this is what I see and it's a negative cyst. I did not find any atypical cells. So let the clinician make the rest of the decision. What about atypical? This is tricky. The interpretational category atypical is heterogeneous and includes cases with reactive changes, okay, low cellularity, pre-malignant changes, dysplasia, and cases assigned to this category due to observer caution in diagnosis. So most often you come and you report cases under this category when you see that there are specific reactive changes, right? Sometimes you see cells which you are pretty certain is malignant, but the cells are too few, so you call it atypical. You can even call it, put it in the suspicious category based on that. We'll come to that later, right? And there are certain situations where you are unable to really put in, you are not sure what to write. Where exactly to put it, you can put it atypical category. One of the situations which you might face, we often face, is trying to use the term descriptive. Now, as far as this particular PSC system is concerned, you cannot use the phrase descriptive in any diagnosis. There is no place for a descriptive report, right? They're very, very categorical about that. No place for a descriptive report. And under these circumstances, when you are unable to say, it's better to put it as atypical. So this is where you can put it, okay? Atypical. the risk of malignancy may change between the risk of malignancy, the risk of malignancy in such cases can range from 45 to 88% depending on which study you're looking at. One of the places where it can be very helpful, suppose you see a tumor which looks like a neuroendocrine tumor, you're not absolutely certain, you would like to do some immunocytochemistry, but you do not have enough material for immunocytochemistry. There are situations, a solid tumor, we are not very sure whether it's a neuroendocrine tumor, whether it is a SPN, you are not very sure, okay? So in these cases also you can put it under the term atypical and then write a note. These are the things which you're considering, but you cannot really make a definitive diagnosis. About neoplastic, this is a tricky area. Many people may find it confusing. Neoplastic is divided into two groups, benign and others. So what is a neoplastic benign? Neoplastic benign are lesions which you are able to diagnose and give a specific name, and you know that they're benign lesions. Most often they are serous cystadenomas. The rare cases of pancreatic teratomas, schwannomas, lipomas, they are put in this particular category called 4A, neoplastic benign. But then there is another group which is neoplastic others. The typical tumors in this group are pancreatic neuroendocrine tumors, solid pseudopapillary tumor (SPENs), and neoplastic mucinous cysts of the pancreas. These are the ones which are neoplastic others, and there is a reason why they have been put under the others category. So what about the neoplastic benigns? The serous cystadenomas are the most commonly diagnosed lesions in this category. You can use low CA levels and low amylase levels to support, but remember that there will be MCNs with low CA levels. I have already spoken about that. By using molecular pathology, you can reduce the numbers of MCN, but still there will be MCNs with very, very low, which are going to have low CA levels. One of the things which has been suggested as a good cytomorphological indicator to differentiate between serous cystadenomas and MCNs is the presence of hemosiderin-laden macrophages strongly favor a diagnosis of serous cystadenomas. But all these are coming into consideration. They are going to come into the pictures only when you are differentiating a serous cystadenoma from a mucinous cystic neoplasm which does not show the typical thick tenacious mucin. I told you that 50% of mucinous cystic neoplasm do not show that clearly grossly visible mucin or even microscopically visible mucin where you are absolutely certain. So it is the differentiation from those mucin poor, grossly mucin poor kind of mucinous cystic neoplasms and serous cystadenomas where if you find hemosiderin-laden macrophages, because it is believed that in the walls of these serous cystadenomas there are blood vessels. I told you there can be hypervascular, they bleed, and there is a lot of hemosiderin. So that hemosiderin come into the cyst fluid. So when you differentiate between these two, hemosiderin-laden macrophages can be of help in supporting a diagnosis of serous cystadenoma. Why do we use this term neoplastic others? These are neoplasms which are either pre-invasive or pre-malignant neoplasms, IPMN and MCM with low, intermediate, or high-grade dysplasia, or low-grade malignant behavior like pancreatic neuroendocrine tumor and solid pseudopapillary neoplasm. These warrant distinction from aggressive, high-grade malignancies. For example, pancreatic duct adenocarcinoma and neuroendocrine carcinomas. This is very tricky. I do not want to make anything get lost in translation. So these lines that you see over here is a cut and paste from the original article. This is exactly what the people who got together and put the PSC system together decided to write, and they're very clear about this. So I just have copied that particular paragraph from that article into this. So if you have any doubts, this is what you have to look for. That why is it put under others? Because they are not surely, many of them are not surely, we are not very sure about the exact malignant potential, and they wanted to differentiate them from the ones which are like malignant, like pancreatic duct carcinomas, acinar cell carcinomas, neuroendocrine carcinomas, lymphomas, or what have you. Right. Suspicious. So what about suspicious? Now suspicious, we just wait to see what are the common scenarios and then we see suspicious. So suspicious, we are going to say, when you differentiate well-differentiated adenocarcinomas from chronic pancreatitis. So there are situations, we are going to see a lot of it during the next session, on the next lecture. It can be very difficult, almost impossible at times, to differentiate a very well-differentiated adenocarcinomas from chronic pancreatitis. So in those circumstances, you can call it suspicious. Pancreatic adenocarcinomas with low cellularity can be called suspicious. And I said this, you can also put it into the atypical category. Whether you want to put it in atypical or suspicious will depend on you, right? And the grade and how bad the cells look. Put them into suspicious category. And sometimes GI contamination with reactive cells can closely mimic malignancy. So these are usually the scenarios in which you put stuff under the suspicious category, and most often than not, in fact, in our study, I think all the cases which we call suspicious actually turned out to be malignant. The risk of malignancy is about 96%. So you call something suspicious, basically you calling it malignant, right? And they are obviously going to go to that part of the algorithm, but they are going to treat the patient with surgery. Positive for malignancy, the last of this, and it means that there is an unequivocal diagnosis of malignancy. We're absolutely certain, and I'm not going to discuss this any further. So what has happened is that since 2014, a lot of laboratories around the world have been implementing the Pathology Society of Cytopathology terminology system. And in 2019, there was an editorial which was published in the Journal of the American Society of Cytopathology, and I decided to just show you the conclusion. Implementation of this system for reporting has been to date an overall successful experience worldwide, multiple centers around the globe reporting better risk stratification. That's very important, because it's all about our main, what you are doing in cytopathology is in pancreatic lesion, we are risk stratifying stuff, improve sensitivity and specificity, and easy implementation of the system compared with conventional cytology. Now, this particular system, of course, requires that for the full implementation, yes, you need to use fluid biochemistry whenever necessary. We need to use molecular cytopathology, and we have seen that how these can enhance the sensitivity, the specificity. But there are situations where you may not have enough material, where you may not have the facilities. And what do you do under those circumstances? In order to take a look at that, we looked at our material and the applicability of Pathology Society of Cytopathology system and reporting endoscopic ultrasound guided fine needle aspiration cytology specimens of pancreatic lesions in situations with limited availability of ancillary tests. It doesn't mean that there is limited availability. There are situations where you couldn't do ancillary tests or ancillary tests were not done. Under those circumstances, how you can use the system. So if you want, you can take a look at this article. This was published in January 2020 in Cytopathology. So with that, I think this is the last slide. Thank you very much. Thanks for your time. Thank you, Nadeem. And I think it's the last slide. Yeah, I'm ready to take questions. Thank you.
Wow, wonderful. Excellently done as usual, MRINMAY. Wonderful presentation.
Thank you.
And it is indeed an eye-opener for everybody, doing FNA and especially doing FNA of the pancreas. And this article of yours is very relevant to our setting as well, because we are also working in a very limited resource available situations. And I would love to read that article and see exactly how we can implement these things. Compared to other criterions which have been put forward in cytopathology, like the PAP aspects of cervical, the Bethesda reporting, the Bethesda of the thyroid, the PSC of the pancreas is yet to gain grounds, particularly in all areas of India, as we can see. Yes, it is being applied in the bigger centers, but in the smaller centers and in the peripheries, is still not so much penetrative. I don't know how it is done at your place, if everybody is following that or not.
Yeah. Yes. Yeah, well, you see, nowadays, all the cases of cyst fluid and where pancreatic cysts are aspirated, the gastroenterologist directly sent the material for amylase and CEA. We get the amylase results pretty soon, but the CEA results, it goes to a different hospital, so it takes a couple of days to come back. And before many of the times, almost always we call the gastroenterologist and ask them about the CEA results. So you get them. We have not yet started doing molecular cytopathology tests on pancreatic cyst fluids, but hopefully sometime soon in the future we should be able to do that sometime. Let's hope that we are able to do it. But yes, nowadays almost in all situations in pancreatic cysts, the gastroenterologists, they send the material for biochemical analysis. But yes, there are certain times where actually there is no need, because when there is a very grossly cystic lesion, a gross mucus lesion, mucus-rich lesion, there is no need actually. You can just look at it, but they actually send it in all cases. Sometimes they're unsuitable because they're too thick, but that's a different story. Sometimes the amount may not be enough.
Right. Madam Kusum Kapila is here if she would like to say something, comment. Right, fair enough. Thank you, Dr. MRINMAY. There are no questions on the YouTube. This is a very important lecture, and I think we need to go back and listen to this again and again. It is really an eye-opener. I went through it and I realized that it is very important for us to understand the subject very well because we must, in the clear-cut malignant lesions, it's fine, but in most of the other lesions, I think we are not up to the mark. I would admit that, right? And I think this lecture of yours will really help us in trying to, improve our skills. Thank you, MRINMAY. I think we will wait for your second lecture on the solid lesions.
Yes, I'll wait for the date whenever you tell me.
We will synchronize it with you.
I'm almost ready with that, so
mutually convenient.
We'd like to, we'll do that.
Thank you so much. God bless you.
Thank you, Nadeem. Thanks for everything. Thanks a lot. Bye-bye. Bye. Bye.